All right. Welcome to the Michigan CASA Education Series. My name is Jane Becker. I'm the Director of Training, and on behalf of Patty Sabin, President and CEO of Michigan CASA, and Jennifer Collins, the Director of Operations, we want to thank you all for joining us today. I'm broadcasting from my dining room table here in Glen Arbor. You veteran viewers know that I like to give a little weather broadcast. Currently, we're at 67 degrees here in Glen Arbor, and we expect to top out at a sweltering 79. So use the chat box to share your love of this recent warm up. I know downstate you're having much worse temperatures. Michigan CASA wants to thank GMB Foundation for their generous gift that will support our ongoing education series trainings through 2022. All right, first I want to give a little bit about Michigan CASA for those of you who may be new to us. We are a nonprofit organization that knits our local programs in 28 counties in Michigan together by providing support and services such as learning opportunities, marketing help, and opening new programs. All of this is in order to change the lives of abused and neglected children throughout the state of Michigan. And our end goal is the same as yours, to end the cycle of child abuse and neglect one child at a time. We're so happy to have our volunteer advocates who want to learn more about this topic so that they can represent their child's needs more effectively. You stand up for children. You give foster children a voice. And because of your advocacy, that a child will be more likely to find a safe and permanent home, more likely to succeed in school, and half as likely to re-enter the foster care system. You have our profound gratitude. We also welcome all the local CASA staff and our colleagues from associated organizations. Thank you for all you do to tirelessly support our children. Now, this webinar is being recorded and it will be uploaded to michigancasa.com to that website. Because it's a webinar, you participants are not seeing your little square, your little rectangle on the screen. But you can still interact by using the chat box. And I like to just say that the chat box is that perfect place for when little comments that you would make if you were in person at a presentation and you'd lean over to the person next to you and discuss something. So lean in through the chat box. But if you have a question for our presenter today or for me, please use the Q&A box. That's the one I'll be watching for questions. So if questions end up in the chat box, they're easy for me to miss. Put them in the Q&A box, please. And then that way we can make sure we get to your questions. All right, now I want to tell you about our presenter. Michigan CASA is proud to bring you Renee Orr of HRA Psychological Services. Renee has been providing therapeutic services to children and families for 25 years. Having spent a good deal of her career in child welfare and residential care services, Renee has developed vast experience in addressing childhood trauma. She has worked closely with children impacted by neglect, sexual and physical abuse, sexual acting out behaviors, and attachment difficulties. Renee has education and training and expertise in providing mental health services for parents and children dealing with divorce, anxiety, grief, attachment difficulties, depression, behaviors related to prenatal exposures, specifically FASDs, which we're going to hear about today, and foster care and post-adopted adoption related issues. So without any further ado, I want to welcome Renee Orr.
Thank you, Jan. Good morning, everybody. I just a little bit more about myself, just to tell you some more of my experience with FASDs. While I was in residential care for 25 years, I was in residential care working and really started to recognize the FASDs being a crucial missed diagnosis in our foster care system. And so I really started learning some more and really kind of recognizing that there were so many of these kiddos that had the alphabet soup of diagnosis after their names. And often when I really dove into those cases, they were often misdiagnosed. They were really under the umbrella of fetal alcohol. and people were responding to their behaviors. And we'll talk a lot more about that today. But also a little bit about myself, and that I, in addition to working in foster care and then going into private practice, I have also been a foster parent for 15 years. And have become an adoptive parent as well, adopting 4 children out of foster care, one of whom has fetal alcohol herself. And so I'm also parenting a child with fetal alcohol. And also in relation to foster care, I sit on my local region. I'm in Grand Rapids, and I sit on my local region's foster care review board. Now that I'm not in the agencies anymore, it's nice to still have my hands in foster care because it really is my passion. So that's just a little bit about where I come from and where some of my passions have led me within the foster care system. So I thank you as the CASAs for your role in foster care. I really have always admired the CASA workers. I've always really relied on them in my own family. When I have foster kids, I've always relied on the CASA workers. And so I appreciate all your advocacy and what you all do. So I'm happy to be here today to talk with you a little bit about fetal alcohol. I have some goals for today. So when I thought about this training and I talked with Jan about what CASA was looking at, I really picked the training that I provide to parents and caregivers for children with fetal alcohol, because I thought your role is so crucial in being in the homes and being allies with the caregivers, that the strategies that I teach parents are really what I want to teach you so that you can then be the voice into the homes and to the parents. And so my goals for today is to help you understand and recognize what are some of the symptoms of fetal alcohol, because again, so many of our kids in foster care, particularly, and kids just with fetal alcohol in general, often are not diagnosed properly. And so better understanding those symptoms can be the red flags that you need to get that ball rolling. I'm also going to speak a little bit about, and one big takeaway I want you to have is understanding the need for the diagnosis. The diagnosis is crucial because it will help the child beyond foster care. It will help them as they enter into adulthood. It will help them transition through their life to be diagnosed under this umbrella of difficulties. And we'll talk a little bit more about why that's so crucial. And then I also want a takeaway for you all to be just the tips and the strategies that you can provide to the caregivers, whether it's foster parents or children reuniting and going home with bio parents, whatever the case may be, just some tips and strategies. And so we'll talk a lot about that as well today. So let's talk a little bit about what is fetal alcohol. This has changed a bit over the years, and it is now looked at as like an umbrella. When we say FASDs, it's like an umbrella term because there are various diagnoses underneath that, most of which are medical diagnoses. And so you have to, this is a part of what makes the diagnosis so difficult to get, because it has to be diagnosed by a physical, like an MD, as opposed to psychologists and psychiatrists. And so there is some movement within the clinical world in the DSM in adding a component of fetal alcohol exposure processing disorder, I think is what they're going to call it. And it's right now it's just in some negotiations and in the appendix of the DSM, but it's not fully something that clinicians can yet diagnose. And so there's a lot of advocacy and movement towards that. So again, there are a lot of diagnoses under this umbrella. So when we say FASDs, there's different levels of diagnoses within that. And so really, one simple way to think about it is it's a disability. The reason that it needs a physical diagnosis is because it is a disability. It is brain damage. So there is, there's a lot of work right now on preventative measures because it is 100% preventable. This is a diagnosis. This is a disorder that people have, a disability that people have that is 100% preventable. What leads to this diagnosis and what leads to this disability is simply the mother drinking during pregnancy. And when we look at statistics, we know that 45% of pregnancies are unplanned. And so if women are drinking and they don't even know yet that they're pregnant, that alcohol is impacting the fetus at that time. And so oftentimes women find out later and then they go, oh my gosh, I went on that bachelorette party or who knows what, but babies are being exposed and women sometimes don't even know. And the other thing is that there's a big push for, there's a lot of misunderstanding around consumption of alcohol during pregnancy. There are a lot of people who think that it's the lesser of the evils, that it's better than drugs, that there are even doctors who sometimes say to women like, oh, 1 glass of wine, that will be fine, that kind of a thing. And that's still kind of going on in our society, that some doctors are still saying that that's okay, that there is like a safe amount. And there is, in the fetal alcohol community, we are all very clear that there is literally no safe amount. There is, because it's unproven, it's not been studied enough to say, oh yeah, if you have 1 glass of wine a week or something, that won't impact the baby. There's been no proof of any of that. So we say very clearly in the fetal alcohol community, there is no safe amount. And so the other thing that is a misconception of fetal alcohol and the diagnoses is that, and I've even had a medical doctor say this to me one time, oh, that child doesn't have fetal alcohol, they're too cute. So there's facial features of fetal alcohol. And there's a lot of people that still really believe that if you don't have those facial features, you don't have fetal alcohol. And that's a huge misconception as well, because fetal alcohol facial features only show up if the window of consumption was, I think it's days 19 through 22 of pregnancy. So any other days of drinking during pregnancy don't result in facial features. So it's a very, very, very small percentage of kiddos with fetal alcohol who have facial features. And some of those facial features are a thin upper lip, a smooth, between your nose and your lip, or some eye measurements, and they're kind of more almond shaped eyes and spacing between the eyes. In the bridge of the nose. And so those are, again, very, very few, but there's still a lot of misconception that if you don't have those facial features, you don't have fetal alcohol. And so that's one takeaway today as well that I want you to be real clear on as CASA workers and advocates, that we can see the other ways that this disability is playing out for children, and it's not just physical. In fact, it's, often we use the phrase fetal alcohol is an invisible disability. It's a disability that children have that we have to accommodate for disabilities, right? And so it's a disability that we don't see. It's not something that we can recognize when the child's walking down the street, oh, that child has a disability, and we have to accommodate. So it's often misconstrued as behavior, and it's really not. It's really brain damage, and it's a disability. And when someone has a disability, we as caregivers accommodate for that. So that's a big piece that we want to talk about. Also real quickly, so symptoms and impacts of fetal alcohol are dependent on a couple of things. They are dependent on how much alcohol was consumed, and also the dates and times when alcohol was consumed, because the brain is constantly developing during pregnancy. And so if different parts of the brain are developing on different days, if that's the day the consumption happened, that part of the brain is what's impacted. So that's the other piece, is that children with fetal alcohol have some similarities, but yet they can be also very, very different from one another in the way that their disability plays out behaviorally. So I do want to say a little bit more about the importance of diagnosis. And again, it's crucial as children, particularly in the foster care system, and they start aging out. It's really important. And I had a case recently on my foster care review board role where a child is clearly fetal alcohol and has been reports over the years. People even allude to it. They speculate it. They talk about it's a possibility, but no one's officially diagnosed this girl, and she's turning 18. And I was really advocating at that foster care review board hearing that she still get the diagnosis, because when she's 18 and she's an adult, when she has some symptoms of her fetal alcohol, which will look behavioral, she's going to end up with a lot of problems with the law, with communities, with housing. I mean, there's just so many other variables that will happen. And with the diagnosis, people can see her as someone who has a disability, right? And so we can respond in that way, which is the most appropriate. One thing for you as the CASAs to know is getting a diagnosis in Michigan is tricky. Getting a diagnosis anywhere is tricky. So the places that you would want to make sure that your foster care workers on cases know is DeVos in Grand Rapids, DeVos Genetics, U of M Hospital, and the CTAC program down at Western and Kalamazoo. So those are 3 places that people can get diagnoses for fetal alcohol. But it's very, very difficult to get in. It's because there's only the 3 places. Wait lists are quite long. So if you're suspecting that a kiddo on your caseload has it, then I would really prompt you to move on to that. Jane, I'm sorry, I didn't ask you to advance a slide. So I was just on the first slide. I'm going to move to the second one.
No problem. Let me share my screen now and get that pulled up for you.
Okay. So we can move down to the, actually it would be the third then.
Okay. So you've covered this, is that right?
Yeah, this is what I just was talking about. I'm sorry, I forgot about
No,
that.
that's quite all right.
So I want to talk a little bit about the characteristics of fetal alcohol. And again, there are some variables and some differences because kids do have different responses, but these are some of the general things that you can see in almost every child with fetal alcohol, is that there's different levels of characteristics. And so the primary characteristics relate to the brain function and things like their learning abilities and the ways that they learn. And we see a lot of poor short-term memory. The way the child is expressing themselves is behavioral, but it's really stemming from the disability in the brain function ability. And so all children with fetal alcohol have some sort of a brain difference. In fact, in my practice with children with fetal alcohol and with parents and caregivers, we talk about the brain all the time. We talk a lot about the brain. Your brain is different, and here's how your brain is different. And we really identify for that child, because your brain thinks this way, this is how we parent, and this is the accommodations that we make. So we see a lot of some commonalities under this primary characteristics are the impulsivity, kind of what I like to call placeholders when children are having a hard time. This is a big one, is auditory processing. And so if a child doesn't understand what you've just said to them, they may blurt out something. Even I have one kid that blurts out a phrase that is highly inappropriate, but it's his placeholder. We've learned not to respond to it because it's simply his placeholder. He's trying to process what you just said to him. He blurts this out. And then if you just sit quietly for about 10 seconds, he answers you. And so we see that a lot happening, that the auditory processing is really difficult, but people then respond to the blurt out, right? Caregivers, we respond. And, and so again, going to my child who blurts out something highly inappropriate, we have learned we just stay silent. If we stay silent for a minute, but it's unnatural because as caregivers or in my office as a clinician, he blurts out to me as well. If I were to quickly respond to that as an adult would be, kind of compelled to do, then we escalate the behaviors, right? But if we just give him a minute, we've learned that he can move on, and that's just simply a placeholder. Secondary characteristics are when some of those things are not met. So again, if we were looking at like impulsivity or processing, auditory processing, if the expectation is too high for the child, if the expectation doesn't meet the ability, then the child becomes easily frustrated, right? And so then that's where the bigger behaviors come out. And so if the caregiver can recognize really what the child needs, again, the blurt out, for example, sticking with that example, if the caregiver can recognize that what that really is and respond accordingly by simply waiting, not responding, not trying to consequent the blurt out or whatever, then there doesn't have to be other problems from that. It doesn't have to continue to rise and to escalate from there. So it really is about the support of the caregivers at that point. So, it doesn't have to, we don't have to have secondary level characteristics if the caregivers really understand and can support the child with the FASD. And then the third line of characteristics are really when those needs are unmet. And to be real frank, I see this a lot in foster care because of the misunderstanding and responses to behaviors, and not really recognizing that there's a brain damage going on with this child, and they're just caregivers responding behaviorally. Those needs continue to go unmet. The child gets no support, and more, deeper level consequences start to happen. So what I witness in foster care, examples of this are the child who AWOLs, the child who has been in 19 different foster homes because families say, I can't handle him. Children who start to use substances themselves, children who break the law and end up in the delinquency side of things instead of the foster care side of things. And so in a really tragic characteristic of fetal alcohol, and this is a very, very tragic and sad one, is a lot of people with fetal alcohol die young. It's a horrifying statistics. There's different, across the world. Canada is much more advanced than US on working on advocacy and things like that for fetal alcohol. And they've done some studies that there's an average lifespan of only 36. And it's not because it's these unmet needs. It's the lack of supports. And so then they get into gangs, or they get into drugs, or they, so they accidentally overdose, or they, accidentally hurt themselves in a dangerous way. So it's a tragic one, but it's happening in the sense of being basically a consequence of this unmet need. So we can move on from that slide.
Okay, Renee, before I do, we've gotten a question, and kind of going back, and I'll type this in to your answer, but could you go through the 3 places where we get a diagnosis again, please?
Oh, absolutely. So Kalamazoo at Western Michigan University has the CTAC program, which I know is much easier for children with foster care to get in than other children. So the CTAC program there with Dr. Jim Henry and Dr. Mark Sloan. The U of M program I don't know quite as well. It's obviously in Ann Arbor. And then there's also in Grand Rapids, the Helen DeVos Children's Hospital Genetics Clinic will also diagnose for fetal alcohol.
Great, thank you.
And again, I would encourage CASAs, if you're suspecting this, really advocate for that right away, because those wait lists are quite long, and they can be, children can be on those wait lists for up to 9 months to a year sometimes.
Wow. Okay.
Yeah.
Thank you.
Yes. So with support, this is an important piece. Outcomes for people with fetal alcohol can be wonderfully successful. They can do anything. They can be anyone. They can accomplish anything. They can have dreams. They can have goals. They can have families. They can have relationships, all of the things that anyone else can have with support, right? Again, that recognition of the diagnosis is crucial, because they will, without that recognition, they will really struggle in their interpersonal relationships. Again, the impulsivity leads to all kinds of different consequences in life. And so really they need the supports to address their executive functioning. They really need the help for, as a child, they need help with their planning and organizing to be successful in school. These are the kiddos who, maybe are losing everything, or their backpacks all stuffed with papers, and or they do their work and forget to turn it in, so they really need help with like those executive skills to be successful. And so again, I think that's just crucial to understand that they can accomplish anything that any other person can accomplish. They just really need the recognition of what their disability is, and the supports around them from their caregivers and providers. And then again, protective factors, again, are that early diagnosis, just crucial. I can't say that enough today. And really educating and supporting the families who are caregiving for them, and really making them understand what's happening, helping them with some skills. And we're going to get to some of that today, and how CASA workers can learn some of those strategies themselves so that they can then pass those on to the caregivers of the children that they're suspecting from. So really the families need to accommodate, but they need the tools to accommodate. And so that's our role as advocates and supportive community members, is that we give those caregivers the tools. So we'll move on to the next slide and talk a little bit about another component of fetal alcohol is this developmental age and fetal alcohol. And so this is a really tricky one for parents, because parents and caregivers will say, well, Billy, he reads just fine, right? Like at school, he does his academics really well, but boy, when I ask him to clean his room, he can't seem to do that at all. And so there are different, we have different skill sets in our brains. And so we have to really kind of break down each of those. And this is a really good one to encourage. As a CASA, I would encourage, like maybe at an FTM or something like that, that the whole team work on this. If you're suspecting fetal alcohol, that the whole team at an FTM say, okay, what are these skill sets that the child has, and what age are they? So if the child is chronologically 14, are their social skills really 7? And so then we accommodate for the social skills being 7. We expect that the child's going to act 7 socially because we've identified that that's where he is at. So, the ability to handle emotions. They may physically look 14. They may physically be able to engage in sports that are age appropriate for 14, but emotionally they fall apart when they don't get this, when they don't get the hit that they want to get, and they fall apart on the field, right? And so things like that. Expressive language, they may be like 8 or 9. And so you have to really like look individually at the child, because again, as I said, depending on when consumption happened in their brain development, each child does look different. And some kids, I have met many kids who struggle academically in school, and I've met many kids who excel academically at school, both with fetal alcohol. And so you really have to look at your child and the child that you're advocating for. And so again, I think that this is an important strategy to think about doing if you're suspecting fetal alcohol. Work through this with the whole team, right? So the whole team has a role in saying, well, I really see Billy at maybe this age. And so the really important part of doing this is that then as caregivers and as a team for the child, we are expecting Billy to be social at the age that he is being social. And so we don't then get frustrated as caregivers that he's acting immature or that he can't maintain friendships. We don't get frustrated with that, because we are recognizing where his abilities are and what are his lagging skills, because all children with fetal alcohol have some components of lagging skills. And so it's vital that as a team that we identify what those are and how we then accommodate from that. So it's an important piece, I think, to look at. And I think when I think about foster care, I just naturally kind of think of those FTMs, because the whole team is sitting there and the whole team has opinions and thoughts on this. And so I think it's really important to do that. So the next slide, we'll talk a little bit more about the logic model of this. And so this is really more, we're going to talk again about the disability of this diagnosis. And so Diane Melvin has a book called Trying Differently Rather Than Harder. This is something, again, that would be a great resource if you do have a child on your caseload that you suspect has fetal alcohol. This is a great easy read for caregivers. And so it would be a really good one to hand out to people, or to have, like if your local CASA office or branch had the ability to purchase a few that you can hand to families that are parenting a child that you've identified as fetal alcohol. They are really a good tool for families, because the logic model speaks to that FASDs, again, is a physical condition. It is physically brain damage. This is not willful behavior. It is not behavior. I mean, it is a disability. There are, being kind of crass, sometimes in the fetal alcohol community will sometimes say their brains are like Swiss cheese. There are these divots, right, in their brain that that impact the way that they respond to things. It is truly brain damage. It is truly a physical condition. And if we see that, and if we recognize, and if we as caregivers especially own that we believe that this is a physical disability, then we can recognize that the behaviors are then just symptoms. The behaviors are not willful, the behaviors are symptoms. And so then if it's a disability with symptoms of behavior, we accommodate for that. And that's a confusing part for, I think, caregivers to accept, because I think that there's sometimes a misunderstanding early on that we're saying excuse the behaviors. We're not saying excuse the behaviors. One thing I say to children in my office all the time is, as I mentioned, I always talk about your brain is different, my brain is different, your brain is different, we all have different brains, but we don't excuse our brain. We're not excusing our brain, we accommodate our brain. We give ourselves the tools that we need to make our brain help us be successful, but we don't blame our brain. We're not doing that. But this is a really, really big hurdle, I think, in what I've seen in my career for caregivers. This is a big hurdle for them to jump, to say that they see this as a disability and they have to accommodate, because this is the thing. So trying differently rather than harder talks about shifting your paradigm of thinking. The person who's going to change with fetal alcohol parenting and caregiving is the caregiver. The child is not going to change. Their brain is their brain. The damage in their brain is there. We can't fix that, but we can accommodate. So we are the ones changing. The caregivers are the ones changing. And this is why the strategies and the tools will be so helpful. So again, you can see why this is a really hard piece for the caregivers, because they're in the thick of it with these kids that are impulsive and are blurting things out that are inappropriate and are, maybe seeming to be hyper, but it's a symptom again. And so all of these things, they're in the thick of it, and they say, well, why do I have to change? I want this behavior to change. But again, the behavior is a symptom of the disability. And so I think in shifting some of that thinking, like things, for example, are accepting that the child is not being willful in this moment, right? So the behavior is not willful. Again, it's a symptom. And so rather than saying the child won't do X, Y, and Z, shifting that paradigm to say the child can't do X, Y, and Z. It's a disability, right? And so things like the child is bad. The child is frustrated in this moment because they don't have the skill set for what's being asked of them. The child lies. This is a big one with fetal alcohol, because it's the placeholder sometimes. Did you do this? No. Did you hit your brother? No. So then they're like, well, you lied. I saw you do it. I saw it with my own two eyes. Well, that's their placeholder. That's they confabulate because they are trying to process what you're asking them. And so again, it's like not saying the child lies, they are putting a placeholder in for the moment, saying that they don't care about a situation, shifting that to say they maybe can't identify the feelings to show that they care, to say that they're resisting a redirect, or they're resisting a direction that the parent is giving. You can shift that to say they don't understand. They don't understand the language in that moment. We're going to talk about some sensory processing in just a second here. And one thing is too many words is too many words for kids with fetal alcohol. If they're having a hard time with auditory processing, then we want to be very simple, clear, direct in our language. And so sometimes this idea of oh, they're not listening to me, or they're not following the directions that I'm giving them, it's too many words. And so they don't understand it, and they need time to process that language a little bit. So this is a really big piece. And again, I would encourage you as CASA workers that if you have like a fund available or something, and you could order a handful of these books in your office, they would be really resourceful for families. It's a really good book. It's a very quick read, but it really speaks to the caregivers about really challenging themselves to look at this differently and to recognize that this is an invisible disability. So we're going to shift to the next one. So again, this is a training that I put together for parents and, ideally, but when I thought about this for your role as CASAs, I thought this is a great approach to take too, is to talk about these strategies, to work on these strategies, and give you the tools to then pass on to the caregivers or the children on your caseload. And so my big hope for today is that you learn some of these strategies in order to pass that information on. I want to share with you, one time I had a kiddo who was probably 8 or 9 at the time, and I thought this was such a profound statement. She said, kids with FASDs are having difficulties and parents just need to stay calm and talk about it. And I just thought, wow, she was like a second or third grader. But it was so simple and so clear for her just to say, we're having difficulties, and if people can stay calm and we can just talk about it, we can figure it out. And I think that's a really big takeaway for parents too, and for caregivers. And so something that you as CASAs can encourage foster parents and families to recognize that they just have to stay calm. So we'll move on to the next slide, Jane. So one strategy is we really want to build on strengths. We really need to identify, what are the strengths the child has and what are the interests that they have, so that you can use those strengths as ways to adapt. So if a child is particularly active, and some of them are, I see a lot of kids with fetal alcohol that are misdiagnosed with ADHD. And it's just that they're fetal alcohol, but they just have a high propensity to be active. And so we have seen that a lot of kids with fetal alcohol really do well if their body's active. And so, building in strategies to, keep them busy, getting them involved in various sports throughout the year, getting their bodies in motion so that they can really express themselves well and keep themselves physically active, because they really kind of need that outlet. We see a lot of hyperactivity as, again, a symptom. Let's see, we incorporate things into their everyday tasks. And so things like if they're a child who, again, is active or likes to be busy, really kind of identifying that as hey, come on, Billy, let's go outside and you can help me shovel the snow. And again, keeping their body busy, right? And so encouraging them to do the things that they are skilled at. And so if that skill set is being busy, then praise them and involve them and make them, do some of that. If they're a child who, I have a kiddo on my caseload who's very much like an organizer kind of a kid. And so we've been encouraging that family to have that child sit down and do some meal prep with parents. Let's think about, because that child is just someone who likes things kind of in order and likes to know what to expect. So, okay, let's sit down, let's plan the week, and let's pick out some dishes for dinner, and what do we want on each night, and what activities do we have that maybe this night isn't a great night for that dinner. And they really kind of work through that, and the kid is really skilled at it. So building their strength into an everyday job, I think, is a really good one. We can develop plans and prevent and resolve problems. So for example, recognize when the problems are coming, right? So if you have a teenager who does not do well with unstructured time, but maybe they like to be outdoors, then finding ways to structure their time with something that they enjoy, right? So maybe this is a teenager who's maybe grew up in the country or something and enjoys farm life. And so do you have a local farm that the kid can go volunteer at or something like that? So recognizing that they don't do well with idle time, they start to kind of get into some trouble. Then, okay, what's your interest? What do you like to do? Let's volunteer to do that. Let's find ways to plug in and keep them focused and busy. And then trying to reframe the behavior problems. And this one's easier said than done, of course. Reframing the behavior problems for us as the adults is the challenge, because we are inclined as caregivers and parents to address behaviors. We are inclined to consequent behaviors. We are inclined to say, don't do that, don't, and so trying to reframe those problems as a disability, I think is a real challenge. And so I think as a CASA worker, provide that support to the caregiver. Like, when you maybe recognize some of this as a CASA, approaching the caregiver with a big, so I say always with kids, a big dose of empathy and a big dose of compassion, and then saying, this is what I'm noticing. Because these parents, again, they're in the thick of it and they are frustrated with these behaviors. And so it's really hard for them to reframe. And so when you're noticing that, we want to challenge them to reframe and to better, like, again, they can't, not the won't, right? Like the child won't do this, they can't do this, right? And so if you're wanting to do that, just really give some empathy and some compassion first as you're leading into that conversation to say, wow, even if it's something as simple as this must be really hard. This parenting, Billy, must be a really big challenge. And I recognize that. And but let's try this strategy. Let's try to reframe this behavior a little bit. So again, it's a little bit about focusing on the, where the strengths are and pulling them in, and really like trying to prevent some of the behavior problems with the strengths that are there that the child has. So another thing, we can move to the next slide, Jane. Another thing that we have found is really, really important for kiddos with fetal alcohol is structure, routine, and consistency. Sometimes I jokingly say, when you're parenting a child with fetal alcohol, every day is Groundhog's Day. It has to be the same. Their routine, if it budges, their anxiety goes up, their stressors come on, they go into the kind of fight or flight brain, into their squirrel brain. And what I have found over and over again, going back even to my residential days, I can remember this happening. If you variate one time, that is the new normal. So I have an example again on my caseload of a dad who brings his kid in for sessions from Kalamazoo. I'm in Grand Rapids. They come up from Kalamazoo, and he stopped at McDonald's once. Well, now they stop at McDonald's every time they come because it's the norm. Because now dad did that. It was out of the routine. Dad did it, and now the child expects it. And it's not a bratty, like demanding. It's his brain really now thinks, I go see Miss Renee, I get McDonald's. I go see Miss Renee, I get McDonald's. His brain truly believes that that's the process. And it's not, again, it's not a willful reaction on our kids' part. So again, they need structure. Their brains have a really hard time figuring out next steps. It's really tricky for them. Change is really confusing because their brain just can't adjust. They are rigid, and they have a really hard time with that transition and that flexibility. So when plans change, it gets really hard for them. And this is where we see a lot of behaviors that will look like, tantrums and whatnot in littler kids and things like that. But it really is truly that their brain is confused in that moment because things have changed. Transitions, one way to think about transitions is just a lot of like verbal like cues, but I wouldn't say a lot of verbal. Again, as I mentioned a little bit ago, sometimes that auditory processing is tricky. So finding one, I tell parents all the time, find your language that feels natural to you, but say the same thing every time. So whatever that, I'll give them some ideas of things to say, but you don't want it to sound rehearsed. You want it to sound real. So I say, choose your words, choose the words that get that message across in as simple and concise way as possible, and then use those words all the time. And that will help the child with transitions and adjustments. And so things like meal times and schedules. One strategy I think that's great for parents is to break the day into sections, like as this slide kind of shows, like here's your morning routine, here's our bedtime routine. Visual cues are really, really big for kids with fetal alcohol, even so much as, a visual cue, we think with neurotypical kids, like we think preschoolers, right? Because they can't read the words yet. These visual cues can work with fetal alcohol and are helpful to children with fetal alcohol all through their years. I mean, even, into young adulthood, the visual reminders are easier for them because that comprehension piece that sometimes is the lagging skill for them. And so pictures, visual cues, I think are really, really helpful because too many words are just confusing, and they're good visual learners. And then, breaking tasks down into small steps, because it's one thing to say to a child with fetal alcohol, go clean your room. That's big, that's broad. I don't know what that means. What are you telling me? So you say, and this is the hard stuff for the caregiver because it's more work on your part, right? And so you have to say, go to your room, pick up all the dirty clothes and bring them to me. Go to your room, make your bed and come back. Go to your room, sweep your floor and come back. Go to your room, empty the trash can. So it's more work for the caregiver. And again, I think this is a perfect place for, as a CASA, to provide a little empathy and compassion to that caregiver and then say, hey, this is a strategy that it's more work on your part, but your child will better understand what's expected and will better understand what you're asking them to do and will be able to better do what you're asking. Because when it's too big and too vague, they don't know what to do. And then they melt down and big temper tantrums come and things like that. So I think, I think again, like this is a really good strategy that the CASAs can see and offer to caregivers.
Renee, we've had a question that came in that is appropriate right now. Does this routine requirement eventually adapt, or is this inability to adapt a lifelong challenge into adulthood?
That is a great question. So couple answers to that. One, I think that these routines and structures are crucial and vital, but I also think it's important that parents recognize that as a child develop, their brain is still working and developing, right? And so they may start to really master a skill. And so then maybe the routine does shift just a little bit. And so we have to be able to recognize when that skill is becoming maybe a little less of a lagging skill than it once was. Maybe again, if we look back at that, where are they at age-wise and different skill sets? Maybe now they have become attention to detail was something that was like a preschool level, and now they've become more like a 10-year-old on that skill. And so you as a caregiver need to be able to recognize it and adapt the expectations accordingly. And we have been finding in fetal alcohol with research, again, international kind of research is showing that so those lagging skills, a child with a neurotypical brain is developing here, a child with fetal alcohol is developing, maybe here, but around their early to mid 20s, that gap starts to kind of come a little closer together, and the gap isn't quite so wide. And so, yes, there is some progress that will happen into adulthood, and they can become, very, very, again, they're very capable of success with the right supports. And so again, they really need that advocate. I think parents with children with fetal alcohol recognize that they are parenting for a very long time. These are not the children who at 18 or 20 are ready to be independent. They are still needing some supports, and it will look different for each child.
And Bart is following up on that question. Does all this mean there is a slower plasticity rate with FAS?
Yes, essentially it does. I mean, they have the capability to learn and to change. It just takes them a lot longer because, again, when we think of, the brain is with these divots that they basically have, is just an easy way to describe it, where the brain damage is. We know that our brains are developing for many years, and we know that neurotypical children's brains develop well into their 20s. And so there is definitely, and I guess that's one big takeaway too that I would hope that people hear today is I don't want people to think that there's no hope for these kids, because there is hope. But the hope really comes from people recognizing that this is a disability, and people learning that they have to be the ones to accommodate and help the child and be their support system, And that's where the change can happen for the kid. If we're looking at it as like we're protecting them while they're trying to catch up, you know, there will be some things that they will always struggle with. There will always, there will be some things that will always be difficult, and that will be different for each child as they enter adulthood. What are the things that are their hard things all throughout life? But with supports and with people acknowledging it, they can be quite successful. So there's a lot of hope.
Yeah, well, no, I'm glad to hear that, because that does come into your mind. And just to kind of piggyback on all of this, my own question would be, at what point would you find it appropriate to use the language of the disability right in front of the child, right with the child? Now, clearly not at 3, but at some point, and as a former middle school teacher, we would bring the child into his IEP review, and we would discuss openly, and we'd say, these are your strengths and these are the things, well, you're still working on, and I've got a long list of things I'm still working on too. So at what point would that be appropriate?
Yeah, that's a great question. Thanks for bringing that one up. It's very important. And so I use language with the little kiddos. I use brain differences, right? And so I even, I pull out charts and I draw the brain on paper, and here's how your brain works. And we talk about brains being different at a certain age. And I think that that's dependent again on I think that should be like a team decision of what that age is appropriate for that child. I'm very open with children about what this is. I name it for them. We name it. We talk about it. They have FASD. What does that mean? We talk about, that it's okay to talk about. We talk about that. But again, we always say we don't blame our brain, but we recognize our brain's abilities and owning that it's a disability. And I think it's very appropriate. Kids need to know. Otherwise, they're frustrated. Why can't I do that? And Sammy can do that, and I can't do that. So they're constantly frustrated with what they presume as successes of other children around them, while they're in a lagging skill area, right? Mm-hmm. Yeah, I think it's incredibly appropriate to share with children at the right age and the right maturity level, which is dependent on the child. So,
okay, great.
Okay, so let's move on to the next slide. And this is another one. So sensory processing is a really big piece for children with fetal alcohol. We see a lot of different sensory processing struggles. And so obviously sensory processing is, our senses, and our body takes in feedback from those senses, and our brain then commutes that sensation or what's happening, and the brain then decides, do I respond or not respond, right? And so things like if we wanted to think about touch, like if a child has a sensory processing dysregularity to touch, then they would be the kids who are maybe chewing on their sleeve all day long, or they're putting all kinds of things in their mouth, or they're maybe a fussy eater if their taste is a sensory issue for them. Visually, those kids, they can't find things. Like they'd be sitting right in front of them, and I don't know where I put my backpack, and it's like right there. So they're just like seeing everything that they can't see the thing that they're looking for. So these are the kids that like a busy store or a mall would be like upsetting to them. It would overstimulate them because there's too much to look at. And so we really need to be aware of what our kids' sensory inputs are, and how they then are responding. And so I think that I strongly advocate for families that are suspecting FASDs or know that there's an FASD to look at OT for kiddos, because I think that it goes really hand in hand with the behavioral work. But I think that really like addressing that sensory piece is really crucial to learn what ways is their body responding, how is their body taking in that sensory knowledge, and then is their brain overreacting to it, underreacting to it, and because that is some of that overreaction or that underreaction are some of then the behavioral concerns that we have with kiddos. So Billy, who chews on his sleeve all day, comes home and caregiver says, I just bought you that shirt and you've ruined it already. It's soaking wet. It's got a hole in it. Like, and so you're grounded, so they're getting a consequence for something that is a brain struggle for them. And so working with OTs, they can recognize, it's certainly out of my wheelhouse as a behavioral clinician, but working with the OTs, they really have that wheelhouse and that skill set to identify, like, okay, this is some of the struggles that they're having with sensory input, and here's some ways that we can address it in ways that is not going to ruin every shirt that he has, or whatever the case may be. These are, and again, if you're having a kid on your caseload who melts down every time the parents take them to Meyer because those bright lights and the big space and it's just too much, like, again, those are a lot of those things are sensory related, and OT can really help with them. And so thinking through, like, how is this impacting the meal times and the bedtimes and the morning routines? There may be things that are overstimulating or understimulating the child. And so I think that's a strong recommendation that I say to families with fetal alcohol, is to look into OT services, because I really think that is a great benefit. And I think if families can access OT and behavioral work, I think those things work really well in tandem with each other for kiddos. We'll go to the next slide. So transitions. This is a really hard one for kids. And I think it's particularly difficult for our kids that you'll be most exposed to in the foster care system, because they have had so much transition, right? I mean, again, I worked in residential for 25 years. Though the kids I was seeing were the kids that had already lived in 19 homes, and were now being referred to residential. And so just transition after transition after transition is really, really hard. And it's tricky for kids with fetal alcohol. It's tricky for all kids, but it's particularly tricky for kids with fetal alcohol because they miss even the slow little transitions throughout their day. They miss those subtle cues. They miss those little cues, like, they're at school and it's lunchtime, and then recess follows lunchtime, and they're missing that everyone else is finishing up their lunch and cleaning up. And now they're mad because everybody went out to recess and they're still sitting there, and the lunch lady is saying, finish your lunch, clean up your mess, blah, blah, blah. You didn't get that done in time. But they're missing those cues around them. They're missing that ability to recognize what other kids with a neurotypical brain are recognizing, like, oh, it's time to finish up here because now I don't want to miss my recess time. And so we as caregivers, it's important that we're giving them some verbal cues or some verbal warnings. And this would be a great, if you are noticing this kind of stuff on your caseload with a kiddo, like helping the teachers to understand some of this. If, we might find that a kid is getting in trouble because they don't, they don't clean up their area or something along that line. Well, they're not understanding that cue that it's time to put that stuff away and move on to the next task. They're not recognizing that. And so if the teacher could have a simple, I work pretty closely with some of my kids' schools, and I'll encourage teachers to have, maybe a special signal for that kid. If they're not going to recognize the social cue around them, then maybe the teacher comes up and it's just 2 taps of her finger on the shoulder, like, and then Billy knows, like, oh, that means it's time to clean up this project and move on to the next. And so it can be something that doesn't have to be some great big, now Billy, go clean up that stuff. They don't have to be like recognized for getting the extra cue, but the extra cue is really important. First and then statements work really well with kids with fetal alcohol. So, first we're going to do this, then we're going to go to the playground, because they're fixated on, are we going to the playground? Are we going to the playground? When are we going to the playground? When are we going to the playground? And caregivers get frustrated. And so first we're doing this, then we're doing that, as opposed to not saying, no, we're not going to the playground right now, because that's going to set them off. Right. So first we're going to the doctors, then we're going to the playground. Time is really abstract for fetal alcohol kids. And so I would encourage families to a lot of families, it's just, I think, a natural parenting thing to say, in 5 minutes, and we're going to do this, or, I'm going to count to 10, and then we're going to do that. And so but time and numbers are sometimes not something that kids with fetal alcohol struggle with. So unless you're going to use a visual timer, I would not give kids time frames, because it's just very vague. And so that's not super helpful. I think, again, so pictures is on there. Those visual cues are helpful to kiddos as well. So yeah, we can move on to the next slide. So learning is tricky for kids with fetal alcohol, and it's different for a lot of kids. It's, I say it's unique to all kids, but there's some generalities in it. It is fascinating to me how some kids can be very, very good at their academics, and some kids are very, very regressed at their academics. And then again, it just really speaks to that like, when was consumption of alcohol and what part of their brain was developing. But some commonalities that we do see is cause and effect learning. So consequences, it doesn't make sense, so if a kid does something and they have to sit in timeout, these are not the kids who are going to say, the next time that situation arises, they're not going to say, oh, last week when I did this, I had to go to timeout. They're not going to do that. Their brain cannot often do that. And so and then caregivers are struggling and frustrated with that. Like, we just talked about this. We just had a conversation. He said he understood. He said he agreed. And then the very next day does it again. And it's again, you have to go to that not willful piece. This is not willful behavior. It's an inability to have cause and effect learning. It's an inability to recognize, if I do this, this will happen. For example, I have a kid who, well, my own child with fetal alcohol, one time, and this is more an impulsivity thing, but didn't recognize that if she rolls the window up with her head in it, it will hurt her. And so that cause and effect. And then she did it again. And so that was it did hurt her, and she was shocked by it. But then the next week it popped in her head again, like, I wonder, and she did it again. And I'm like, oh my goodness, like it hurt you and you still tried it again. And so that, again, that cause and effect is just simply not there. And I think that that's another one, as caregivers and as CASAs, to provide the caregivers some ideas of, try not to get frustrated in those moments, because that is, again, it's not that they won't, it's that they can't, right? It's important to keep that one in mind. They can't apply one situation to another, and oftentimes, and remembering short term is real tricky for them. That's a commonality that has been found to be among a lot of kiddos, is that real short term memory is a struggle. They'll remember 3 years ago, but not what they did in math yesterday. And that's a tricky one for teachers, because that short term is a harder thing for them. I hear this from teachers all the time, like, we literally mastered this skill yesterday, and they come in the next day and they can't do it. That's where their brain is that day. Maybe the day before, their brain was up on one of the high valleys, and the next day it fell down into the low valley. And that's just how they're functioning that day. So one thing, what do we do as caregivers? I think it's important for you as CASAs to give caregivers, like, that idea of the little girl who said, if everyone just stays calm, right? Just stay calm. That's the most important part, because I think this is the one that's really hard for the adults, whether it's the teachers at the school, whether it's the caregivers in the home. This is a hard one for them to understand, that what they can do one day, they can't do the next, or it looks like not being able to. We do simple step-by-step instructions. Again, we do simple language, as few words as possible, clear, direct, language for the kids. And we need to be willing to reteach. That we need to be willing that if we just did this yesterday, we may be doing it again tomorrow, because we have to just repetition for these kids to finally, it will click. it just takes a lot of that repetition sometimes. And then offering praise, I think is really, crucial. So, I think recognizing too that, we often as caregivers will say, well, what do you want to do? Or what choice are you making? And then we want them to do that very rapidly. And Diane Melvin, in her book has a wonderful statement of, these are 10-second children living in a 1-second world. So we have to recognize that their learning style is different, and we have to stay calm about that. And we have to be willing to be patient and to repeat things and to relearn things and to re-strategize. That's on our role, because they are a 10-second child living in a 1-second world.
Got a couple questions if
Okay,
this
perfect.
is a good time. Yeah. And this one will go back to the transitioning.
Sure.
Because, and I actually was thinking of this myself. I'm like, life is just a series of, in 5 minutes, we can transition 5 times, right? And so with multiple transitioning equating to chaos, does chaos become their norm?
Yeah.
And if so, how does a family recover a positive norm? And I know you were saying stay calm, but if you could address that a little bit more, please.
And also, one thing I say to families quite often is keep their world small. And it's sad, and again, in full transparency, I use my daughter as an example quite a bit, because I'm living in this as well. I'm a caregiver for fetal alcohol. It hurts my heart how much I have to keep her world small. I want her to do all the things that a neurotypical, she's getting ready to go to middle school. I want her to do all the things that neurotypical middle schoolers do, but it's my job to recognize that she may be functioning at about 7 in this domain and 5 in this domain, and yes, 11 in that domain, and so that's my job as her caregiver. And as a result, I keep her world pretty small. We, some middle schoolers play 2 or 3 things, or they're involved in 2 or 3 extracurriculars at a time, maybe a sport, maybe a club. But with my daughter, we do one thing at a time, because she can't, her brain, it's just that's too many transitions. So I recognize that we keep her world a little smaller. And so I think that is one component to that, because we're living in, and it feels like chaos to them, the ways that we live, and we live in a very fast-paced world, and we live in very busy worlds, but it feels chaotic to them. And so as much as we can recognize that does feel chaotic to them, how do we reduce it?
Reduce it. Good point. And then, and you may have this planned for later on, so we can wait, but this person's also asking, is there any way we can get a list of resources that are available for the family?
Oh, sure. Yeah, we can. I don't have that plan, but what I could do is throw together some resources and send those to you guys, and maybe it could be posted on your webinar page or something along that line.
That would be just beautiful and very generous. Thank you.
I'd be happy.
Yeah, great. Thank you. And then another question. All of these things you are discussing sound similar to nonverbal learning disability. Is there a difference between the two?
I believe that there is, and I think, again, that's not my wheelhouse necessarily. I think that's where I appreciate, as a behavioral therapist, working with the OTs, because that's their wheelhouse, and they can really recognize when maybe it's more of the maybe more of the sensory related type matters versus, and I think this is a good reason why, again, we have to really explore the diagnosis, right? Because we certainly don't want to mistake fetal alcohol either. So if, again, I'm a strong bias in believing that kids in foster care have all kinds of wrong diagnoses, because I've seen it for years and years. And I do believe that oftentimes I have seen many kids with a lot of diagnoses, and they really truly are fetal alcohol. But I also wouldn't want us to start to say, oh, well, we're misdiagnosing fetal alcohol, when it's really like a processing issue of some kind. Yeah, absolutely. Okay. So again, one important takeaway is that is key is appropriate diagnoses. It's really crucial. The next slide, Jane, would be great. So we're going to talk a little bit about impulsivity on this next slide here. Impulsivity is truly a big one for these kids. They one way it was described to me early on in my career by Mark Sloan, actually at the CTAC. He said, kids with fetal alcohol are living life ready, fire, aim. That's exactly how they live their lives. They think it, they do it, and then they go, oh my gosh, and I see this happen all the time. Like they think it, they do it, and then they are like, I've seen it on kids' face in the moment of like, did I really just do that? Like, I think they're shocked themselves that it just happened. And so these are the kids who will hit impulsively. These are the kids who will scream impulsively. These are slides again from my own daughter. These pictures are, my daughter saw the movie A Christmas Story one year and went outside the very afternoon and stuck her tongue to a pole. Gratefully, she had a friend with her who has a neurotypical brain who said, stay here, I'll go get my mom. Well, impulsive, can't do that. So she ripped her tongue off the pole and pulled about 5 layers of skin off her tongue. Impulsive, just think it, do it. And then was very sad, obviously, because she was hurt, and so if they think it, they do it, and then they think through like, oh man, I shouldn't have done that. I have a kid here who comes to see me in my office who my secretary dared to make eye contact with him as he was leaving one day, and he flipped her off. And then he immediately went beyond the door with his dad and said, do you think she's going to come after us? Like, so he thought it, he did it, and then he got scared. And, it was an impulsive act. It was something that he hadn't thought, is this a good idea or not a good idea? But it can lead to huge consequences, right? Like the natural consequences, not the consequences we as parents are giving. It can lead to very dangerous situations. It can lead to hurt, like harm. They can really damage relationships at school with friends when they're impulsive. Other kids don't know how to interpret that. And so I think they have a lot of peer difficulties as a result, a lot of consequences among their peers at school because the other kids don't maybe understand the blurt outs, or they don't understand, we were just playing soccer and you shoved me, like, why'd you do that? And the kid doesn't know either. It's just an impulsive act. And so it's important as caregivers, I think, to to really, again, like control that environment a little bit by keeping the world a little smaller, by keeping, maybe practicing some of those situations that they might come into. I know, like, again, my own daughter with fetal alcohol is getting ready to transition into middle school. We're spending the summer talking about what, we're practicing, we're role playing. Like, how do you take that couple of minutes in between class and not get distracted by everything you see, and you make it to the next class? Like, we're going to be role playing a lot of that this summer and practicing. How do you meet new friends? Because all the elementaries come together in the middle school. So there's going to be a lot of new kids. What do you say to a new friend when you meet them? So that these kids just need help with like thinking things through, so that they're actually living life, ready, aim, fire, as opposed to firing then thinking, right? So that's a really big one. We'll switch to the next one. And this one, as I thought about this training in particular with you as CASAs, I thought this is an important takeaway as well. This is an important slide to really spend a few minutes talking about. And this is one that I would welcome a lot of questions if you have them. This is the stuff that will not work with fetal alcohol kids. And when you look at that list of things, they're all the things that we are taught, particularly that foster parents are taught in some ways of different parenting strategies, right? Like behavior modifications and reward systems and contracts, or if you do this, then, X amount of days we'll do this, or grounding kids, or doing consequences. All of this stuff is really, really not effective because it means that the child has to have that cause and effect thinking, which they really, really don't. And so again, the timeout, the grounding, the consequences, it's not going to prevent the same thing from happening tomorrow. The child is still going to impulsively act. They're still going to do without thinking. They are not going to be able to say, Tuesday when I did that, this is what happened and I don't want that to happen again. Their brain does not function that way. And so this is a really big one, I think, for us to encourage foster families to think about and to say, okay, then what do we do, right? And it really, really, that's about the reframing. It goes right back to that reframing that we talked about, for the caregiver, to shift that paradigm. Remember when I talked about that a little while ago, that it's their job to shift the paradigm and to be thinking that this child is not willfully doing this behavior. Again, the can't and the won't, right? And so it's not that they won't, but they truly cannot in this moment. And so these types of strategies, particularly one that gets under my skin, is the reward systems and behavior mod type stuff, because the level of impulsivity with fetal alcohol, they can't attain that stuff. They really, truly, if you say, do this for 5 days, they will never make it. It ends up being a setup in some ways. And so I think it's really, really tricky. So the things that we do, I say, don't lecture and that kind of thing, but we do talk to kids. We do give them our expectations. We keep it real simple, real clear, and then move on, because they're not going to have that ability to learn that what they did caused this consequence. And it's just not, it just doesn't work. So I think this is a real tricky one, because it's kind of our natural, what we go to as parents. It's what we're taught. It's maybe the way we were parented. It's definitely, I think, tools that we give to foster families when they're getting licensed. And so it's a real tricky one for families. Again, it speaks to, though, the need for the caregiver to reframe the behavior and to re-understand it as not willful.
Can suggestions of things that will not work and will work and what will work, can those be written into an IEP?
Oh, I think so. Absolutely. Absolutely. Yeah. I will say that, and speaking of IEPs, just for a quick second, this is just my soapbox of it. Kids with fetal alcohol really, really need an OHI diagnosis instead of an EI, because again, and I think a lot of kids with fetal alcohol get the EI, but it's addressing the behaviors, but the behaviors again are symptoms. This is a medical condition. This is brain damage, and so it really needs to be under that OHI umbrella, so that it doesn't, we don't want them to say, oh, well, now they've mastered this behavior, they've mastered the skill, they don't need their IEP anymore. Yes, they do. They still have brain damage. So maybe the behavior is now starting to take shape and looking different, and they've learned a strategy or they've learned a skill. The brain damage does not go away. They need that IEP to stick with them all through their education. So I really advocate for the OHI diagnoses with kids with fetal alcohol.
Thank you.
Yeah. The last thing that I say to parents, and I would encourage you as CASAs to talk to parents about, is helping them. And this is just my last slide of just a group of people. Oh, I don't know how that car one got on there. Sorry about that. But finding your support system. It's just crucial. These are not easy kids to parent. They are so tricky, so complex, and particularly the ones in foster care, because they've had so much change in their lives, and they've got so many other things happening in their lives in addition to their brain damage. And so they've got, potential abuse or the neglect or the living between homes, or maybe their first time taken away from home, their first time away in somebody else's house, like so many other things happening. They are tricky, challenging children to raise and to parent. And I think it's crucial that people parenting these kids find support systems. And so that's one thing as an CASA, I would really encourage you, when you're in those family team meetings, when you're meeting with the families, when you're visiting the kiddo, really encouraging those caregivers to find their supports and to find their people, so that they can rely on some people as well.
For sure. Question for you, and I would encourage more questions in the Q&A box, please, from all of our participants. I'm thinking of them on the fly too. I have a long list of them, but again, like you said, a lot gets misdiagnosed. And as a CASA advocate, we're going to get involved with those medical diagnoses. We're going to get involved with the school. And let's say someone is, the child is diagnosed with ADHD, ADD. And we have some suspicions, but of course we're not experts and clinicians and whatnot. How do we approach our suspicion that the diagnosis may not be accurate? Well, I don't want to say accurate, but appropriate.
Appropriate, yeah. And I think that's a great question, because I think that as CASAs, it is your role to do that advocacy piece, right? And so it is your role to start raising some of those discussions. If you suspect that there may be some exposure, if you, and oftentimes, unfortunately, we'll even read in their files that they were, maybe at birth, mom was intoxicated. Well, hello, we certainly have suspicion then of fetal alcohol. And so your voice needs to be a part of that, particularly at the FTMs where all the players are there, all the players are at the table, the whole team, that we start saying, hey, who's taking the lead on this? We suspect this. These are X, Y, and Z. These are some of the things that we see that may or may not, because not my wheelhouse. This isn't what I'm trained in, but can we start, exploring this? And again, the reasons for wanting to explore it doesn't matter how old they get, this will help them into adulthood. Because it's a disability, it's not going away. It's not going to be something that we can teach them skills out of completely. It's brain damage that will stay with them. They will learn some coping and some strategies, and they will the gap will start to lessen, as I said. But we want them to be identified correctly so that they have the supports that they need throughout their lifetime.
Mm-hmm, mm-hmm. And I suppose this could end up being really tough on mom. Feelings of guilt, and once that connection is made.
Yep.
And again, we're not
judging.
Our job. We're not judging, and we're also not. It's not our job to make sure everybody, feels better. But I'm just, again, are there supports for parents in this arena?
Yes, absolutely. And so that's, Jane, thank you for bringing that up, because that is another component, I think, particularly with foster care. Well, I mean, worldwide, that's another reason why so many of these kids are not diagnosed. The numbers of kids with fetal alcohol are higher than the number of kids with autism. But look at how much attention autism gets in our community and how little attention fetal alcohol gets, because there's a huge stigma. There's a huge stigma. There are kids with fetal alcohol and not in foster care, very affluent families, very, well functioning, but mom maybe drank some wine throughout the pregnancy and thought it was okay and didn't think that there was anything wrong with it. Or the mom who didn't know she was pregnant until X amount of weeks and had already been drinking. And so there are all kinds of kids that have been exposed to alcohol, but it's a huge stigma for moms, and it's not something that moms want to agree to. I've even had moms that I've known, and again, as a foster parent, I went into foster care. It's funny because I say sometimes I did foster care wrong because I have 4 adopted children out of foster care, because I believe so heartedly in reunification. Like I truly, it's always my honor to meet the parents the first time as a foster parent. I always go to that first parenting time and am just very attentive to them and tell them I'm here as their support, and I rally them. And I truly believe in reunification. And I've had parents over the time that I've even said, now you're testing positive for X, Y, and Z. Did you ever drink while you were pregnant? And it's interesting to me that is harder for them to say. They'll say, yes, I did heroin throughout my pregnancy, but they'll say, no, not a drinker though. I didn't drink.
Interesting.
And so there's a huge stigma to it. And it's fascinating to me how big that stigma is. But yes, there are supports. And yes, we do, as teams, as CASAs, as foster care workers, as the foster parents, we do have to support the mom in that situation. We do have to say, this isn't about shaming you. This isn't about judging you. This isn't about pointing fingers. What can we do to get your child the best help that they need in their lifetime? And because it's so tricky to get diagnoses, and it's so important to get diagnoses, one way to get diagnoses is mother admission.
I
It's
see.
like a shoe-in. I mean, if you go in to a doctor and you have mothers saying, yes, I drank during pregnancy, they will get fetal alcohol diagnoses. And so
And actually,
criteria.
that is a question that's out there right now. Is an admission or medical record of alcohol consumption during pregnancy still a requirement for the diagnosis? And you said if they say it, boom, it happens. But is it a requirement to get the diagnoses?
It's not a requirement if like the facial features are present, and they will sometimes break down. Like I said, there's those different diagnoses under that umbrella, right? And so sometimes kids will get a different diagnosis underneath this. It's like a spectrum umbrella, right? So it's still an FASD, but it's not, they didn't, there's like these charting system that the doctors do of like, yes, I had mom's admission. Yes, they have the facial features. No, they don't have the facial features, and they fill in this box, and then that is the criteria of each of the separations of the diagnoses. But admission definitely will get a diagnosis. Medical documentation doesn't always. It's not always enough for them to do. So yeah, it is. But yeah, that admission will always get a diagnosis if they're meeting the criteria, of course, but yeah.
And is there a genetic test to diagnose?
That I'm not 100% confident on. I have read, I don't want to misspeak. I don't know for sure.
No, and that's fine. Well, we still have a couple more minutes. If anybody has that last question out there, I'm going through, I took crazy notes during this because I'm thinking of so many kiddos right now. So many kiddos I have once known. But I think one of the things that I think is very powerful that you said is keep their world small, because it is what you, and I think of this for all of our children in this chaotic world with screens that were, sometimes I know when we were raising our kids, I said, oh, I just want to move out into the middle of the country and forget about the rest of the world. Well, I think what I was saying is I want to make the world smaller. Yeah.
Yeah. And I think that is a big one, because I think keeping the world small, sometimes I say that to people and they think, well, you're punishing them for their disability. No, I'm not about punishment. It's about keeping their world small so that they can be successful in it, right? If it's too big and they can't cope with that, then they're having, problem after problem after problem, and their self-esteem starts to drop. They start to feel like a failure, all of those things. If we keep their world small, they have successes often, and they feel proud in those moments, and that enhances the self-esteem. So I think that's the way we have to think of keeping the world small, keeping them small so that they can be successful and find those successes day to day.
Wonderful. All of that is so important to remember. And also the other thing that I flagged, behaviors are symptoms.
Yes.
And yeah, we can't just go after that behavior, because as you said, that's how we were all taught to nip that in the bud, right? And that's not what that's not going to work.
Exactly. And so if we look at that as a symptom and not the problem, right? This is a symptom. The problem being, if you wanted to call it a problem, the problem being the disability of the brain damage, but this is a symptom of it. And so to not respond to that in a natural way. Again, my kid who, swears every single time. If his mom says, pick up your sock, I mean, it's the same thing he says every single time. If I ask him how his week was, when he comes into my office, I ask him how his week was. It's exactly what he says to me. And then I wait 10 seconds, then he says, oh, it was a pretty good week. He just, he's processing that. And so if I were to say, I'm not going to see you because you say that to me every time I ask you something, then I'm responding to his behavior. And that's inappropriate because it's a symptom. I can recognize that swearing at me is a symptom to his disability.
Correct. Oh, great. Thank you so much for that. And thank you so much for this presentation. It was very, very informative. I tell you, Michigan CASA is going to keep you close, Renee. You got a lot of great information for us. Well, and this is something that we can use today. When we go out to visit our child today, we can use, even if that child doesn't have fetal alcohol, we can use a lot of what you said. So I really appreciate that. I did record this session. It will be loaded up to the michigancasa.org website. Look for it under training archives under the learning tab. And then stay tuned and for any of our next education series presentations. We are going to take a short hiatus during the months of July and August, and but that would be a great time to go back to michigancasa.org, go to the training archives, view some past presentations, review, look for the resources out there that can help you in your advocacy. They're out there and available to you. So thank you so much, Renee, and thank you to all of our participants today. Go enjoy a great Michigan summer.
Thank you, Jane. Thanks for having me.
Oh, you're welcome. And